Hello, guys.
Hello, very
Hi.
good
Hello,
morning
Mirek.
Hello, welcome you.
Hello,
from
Kwon.
Germany.
Hi.
Hi, Robert, again.
Hi,
Nice to
Dobrin.
see you. Uh, this session, we will be moderators with Dr. Mirosław Ferenc from Bad Krozingen. Professor Gil will be also a discussant. And I really happy to see Dr. Bong Kwon-koo from Korea, one of the in physiological assessment of coronary lesions in general. So the first speaker will be Dr. Koo. We have his talk on record, and then we will switch live for discussion.
Hi, everyone. I'm BK Gu from Seoul National University Hospital, and it's my great honor and pleasure to participate in this 10th Jubilee Bulgarian Bifurcation Intervention course. Today, I'd like to talk about how to decide the significant side branch. Why we are doing revascularization every day in the cath lab? It's because to relieve angina, ischemia, and prevent LV dysfunction, and in the high end, to prevent myocardial infarction and cardiovascular death. When we encountering this kind of lesion, it's quite straightforward that revascularization, either by surgery or PCI, should be performed to meet these requests. However, when we are encountering all these different bifurcation lesions involving several different side branches, I'm wondering whether the revascularization is really necessary to meet these goals. To answer that kind of questions, let's just think about what we know and what we do not know. First thing we know for sure is that there is a difference in clinical relevance between the main and the side branch. When we sequentially occlude the LAD and diagonal branches, as you can see here, diagonal branch reproduce the chest pain during occlusion only in 40% of cases, and ST segment elevation assessed by the 12-lead surface ECG was encountered only in around 40% of the diagonal branches. So this simply illustrates that there's a difference in clinical relevance between the main and the side branches. And this reflects that unfortunately, we don't have solid criteria for clinical relevant and important side branches while fixing these kind of very different bifurcation lesions every day in the cath lab. To solve this problem, let's just simply review the guideline. So this is European guidelines, and it is say that for the prognostic indication for revascularization is the lesions or branches that supply large area of ischemia, for example, 10% of LV or abnormal invasive FFR or non-hyperemic pressure ratio. So as there is FFR, let's simply thinking about the clinical importance of side branch FFR according to the clinical outcome from randomized clinical trials or the registry data. So if FAME1 story makes sense in the bifurcation lesion, FFR-guided side branch intervention, the outcome should be superior to the angio-guided intervention. However, from this registry data, from this randomized data, the clinical event rate is not superior, but exactly the same between the FFR-guided side branch intervention and the angio-guided side branch intervention. Why? Why the FAME1 trial results cannot be translated into the bifurcation, specifically to the side branch lesion? It's because there's a difference in the ischemic depth and width in terms of clinical implication. Here you're looking at two FFR tracings, one FFR 0.73, the other is 0.51. So when you should select one lesion which is more important from this tracing, I should say that this one is more important and more significant. But when you see these angio images, your answer may be changed. I would definitely say that this value is more important, has more clinical implication than this value, which is achieved from a rather small diagonal branches. So while dealing with the bifurcation, especially side branch FFR, the number one important message or the insight is that the ischemic depth is less important than ischemic width. So the territory should be the first step in dealing with the bifurcation intervention or the assessment of bifurcation lesion. Having said that, let's think about the way we identify the territory of myocardium and ischemia of the side branches. There are several ways, and we are having more and more new technologies from CT angiography, but most of us are the interventional cardiologists, and we should decide this territory in the cath lab. And for that, the most common used index is that the reference vessel size. Because in all textbook, it is written that side branch PCI is recommended for large branch with diffuse disease. So how large is real large? But we know that this large by the angio or QCA has several limitations. There should be an inter and intra-individual variability. And while fixing this kind of lesions, and we can simply know that we cannot measure the diffuse disease or total occlusion vessel size. And the worst thing is that it is not accurate for territory estimation. So if I do the QCA for these two branches, this one is a little bit larger, but I will have the similar results. So if I estimate the territory by this QCA vessel size, these two branches territories should be the same. But if you see the real territory, there's a huge difference between this territory and this territory. So this is the big limitation of the estimation of territory by the vessel size. And this was translated in the differential outcomes in the BBC Nordic study and EBC2 study. While applying these angiographic criteria, there was no discrimination abilities for the outcome or to discriminate the beneficial effect of the side branch intervention. We've been working on this issue for several years. So almost 10 years ago, we developed this new scoring system for side branch territory, defining as a SNU score incorporating size, number, and location. This branch, similar size, but this branch's score is 3, and this branch score is 2. And in this study, we defined that score 3 means the relevant side branch. And several years later, we also developed a modified SNU score, now integrating the concept of ubiety, and size, number, ubiety, and location was integrated in discriminating the side branch territory. However, after developing and working for several years for this new scoring system, I learned that it is very difficult to apply in daily practice. So let's just think about the territory and its determinants of the diagonal branches. We know that diagonal branches for the anterior wall and some part of the anterolateral wall, so it can supply blood to around 10 to 25% of LB territory. As this territory is shared by the diagonal branches and obtuse marginal branches, simply there are some elements we can consider as a determinants of its territory. First thing is number of branches. As number of branches gets higher and higher, we can simply expect that the territory of each branch gets lower. The other thing is that the circumflex vessel size. So it's interesting to realize that the diagonal territory is theoretically and practically determined by the circumflex size because they are sharing the territory same territory between the diagonal branches and obtuse marginal branches. And if the whole territory is set, the distribution of each branch is determined by the dominancy of each branch among the all branches. So here is a two case example where there's only one diagonal branches. So this branch supplies 18% of total myocardium because of small vessel, small circumflex. But this, due to these very big circumflex and very big obtuse marginal branch, this territory supplies only the 7% of mass. So this circumflex artery dominance matters in defining the whole territory of the diagonal branches. Another important element is the number. Here you see that if there's only one branch, average territory is around 12%. But if there is 3 or more branches, territory of each branch is almost 4%. So unless you completely obliterate 2 or whole vessels, you cannot cause 10% or more ischemia. And when you have 2 branches, the territory should be in between, and the dominant branch can supply more than 10%, but non-dominant branch cannot supply more than 10%. So this is a simple metric: number, circumflex territory or circumflex size, and dominancy among and between LAD and circumflex, so that these are the key elements we selected to assess each branch's clinical relevance or the clinical significance. So this is data when we divided the vessels into the significant, defined by CT territory more than 10%, and insignificant. You see that it's a very simple math, that the small branch number and dominant vessel and circumflex size was a key determinants of this territory. So when we analyze this into more sophisticated analysis, when you simply encounter the number, dominancy among the branches, and circumflex dominances, its diagnostic performance is quite high. AUC 0.92 and accuracy 0.91, so it's excellent. And it's, even if you add the size according to the QCA, there was some improvement, but the improvement wasn't that much, so that applying this concept, simple metric number, relative dominance, and circumflex size will be good to be applied in daily practice. But still, you have to consider the number, dominancy, circumflex size in daily practice, so that I would like to have a more simple solution to answer this question using machine learning technique. And this is the model which was developed by the machine learning decision tree. So if you want to assess or to define the diagonal branch which supplies more than 10% or important diagonal branches, in the beginning, you are starting with the 15% chance. So in all diagonal branches, there's a chance of 15% of the one branch supplying more than 10%. This is quite similar to the current 2-stenting proportion in all bifurcation lesions. And first, you just count the number of branches. If there's a single diagonal branches and circumflex is not dominant vessel, there's a chance of the 74% that this applies more than 10%. But there's more than one branch. If there's more than 3 branches and this is non-dominant branches, you have a 2% chance. And if you have 2 diagonal branches and bigger one, you have a 55% chance. So that applying this simple metric will be helpful in defining the lesion significance. And the performance doesn't matter even if you apply the size, so that even without size, you can make a good decision. And another very important lesson you have to learn is there is a difference between anatomical territory and ischemic territory. So this branch, unfortunately, totally occluded after LAD stent implantation. Is from visual estimation, you may expect that around 15 to 20% territory, so there should be a significant sequelae. But as you can see in this MR images taken after this procedure, there was a injury, but the amount of insult was only 7%, and there's no reasonable motion abnormality in this territory and also in this territory. So ischemic territory is smaller than the anatomical territory. This is very important. So we have to visualize, or we have to train our eyes for clinically and prognostically important branches. And these are territories where the ischemia is more than 10% by myocardial perfusion imaging, 15, 11, 10, and 12%. So in summary, ladies and gentlemen, identification of clinically important side branches should be the first step of bifurcation intervention. And in side branch territory, presence of ischemia does not guarantee the clinical importance and the necessity of PCI of that branch. Use of simple angiographic attributes, number, relative dominance can help select the clinically important side branches. And another important message is that the ischemic territory is smaller than the anatomical territory, so you should train your eyes for branches that may cause 10% ischemia. So in conclusion, you don't need to do too much even for physiologic assessment, imaging, PCI for small side branches. Thank you very much for your kind attention.
So, dear Professor Kuh, congratulations to your lecture. Very nice overview from my point of view. And the question is, according to your daily routine, so in how many cases, if you are not really sure what to do with a side branch and to consider as a significant or not significant, in how many cases do you perform FFR measurements? It's a 10% or 20% or even less? Please unmute. We can't hear you. There is probably
Проблема с звуком.
Can you unmute? Yeah, good.
So
Yes.
can you hear me?
Yes.
Yes, now it's better. Hi.
Okay, so you can hear me, okay?
Yes.
Yeah.
Okay, so that nowadays the use of FFR in side branches is much less than before. So I would say it's around less than 5%, because we know that the first is that most branches are not significant in terms of territory, not in terms of ischemia or not. And second thing is that there has been now so much data supporting that the 50-60% stenosis in general does not cause ischemia. So we know that very well. So we learned from previous experiences, so that the uses of measuring physiologic indices in side branch lesions are becoming less and less.
Yeah.
Yeah.
That's correct. Maybe some questions from Yves.
Yes. Hello, Kwon. Nice to see you.
Hi.
What are you planning, or have you done already analysis regarding lesions that we treat less frequently, like circumflex and marginal and distal right?
Yes, that's another very important element, but it's not. It's first thing is that it's not easy to get the data, and while working the CT data, the problem we have while working the CT data for defining the function myocardial territory is that generally there's a tendency of overestimation of the branch territory while working with the CT and PL branches and obtrusive marginal branches, so that we are actually stopping here with almost diagonal branches. But one good thing is that the most frequent branches we are dealing in daily practice is that the diagonal branches around 60 to 70% in most bifurcation lesions, so that I may have to be sorry about that, but we are not planning to do a further analysis in obtuse margina and right coronary artery branches.
Maybe you can suggest during the next meeting in person, I hope, to have a collaborative work with centers having a CT scan, for example. Yeah. I suggest that. You may be the leader of such a trial.
There's one more question remark from Professor Gill.
So thank you very much, Professor Bon-Cookop, for such a very nice, interesting, and very wise presentation. Because first of all, we need, let's say, 2 steps of this kind of assessment. Pre-procedural, because starting the procedure, we should know the weight of branches, the importance of the territory of distribution, blood distribution. But another problem is to let's say to assess results of our treatment, especially when we believe and we treat patients with provisional T-stenting, whether we should leave or to improve. So this is 2 steps. We need this kind of assessments or assessment on 2 steps. And looking at your data, at least for left coronary arteries, mainly LAD with diagonals, I see the possibility to construct or to invent a calculator. Because, of course, we should estimate every patient individually. But, you know, if you have today only some intuition, what is important, what is not important, at least this kind of help, advice by this calculator would be very great. So I really recommend you, I beg you, let's say to complete at least for LAD and diagonals, this kind of work, because already with this data, I see that there is a possibility to let's say to invent such a calculator, which will be very widely used for sure, as a kind of help, how far we should go with the treatment to optimize the result.
Yes. So, Robert, thank you for your comment. I think according to the time schedule, we should go ahead with the next presentation. This will be Professor Vasilev, how to decide to treat or not to treat the side branch in the provisional stenting strategy. Welcome.
Thank you, Mirek. My talk will be continuation, actually, of talk of Kwon. So this is, I'm also follower of the provisional side branch stenting philosophy, because this is a philosophy. Just start with provisional, and from time to time, maybe 10 to 20%, if you have a significantly diseased side branch, it should be stented. However, the problem with the side branches arises mainly with the size of the side branch, and what is much more important is the territory of side branches, which was already mentioned from Kwon, and how to do the measurement of myocardium at risk from the cath lab, from online. When you have a patient on table, you don't have data from CT before, and you have to orient yourself how to measure the territory at risk. And the tool which we have from many decades is the Barry risk score. This is how we use the Barry risk score in angio. You can see the branches are measured, the relative importance of every branch is measured depending on its length regarding to the length of the left ventricle. And on this picture, you can see the relative importance of all the branches which you have in this patient. If the branch is less than 1/3, but it's deemed important, it receives 1 point. If the length of the branch is between 1/3 to 2/3 from the left ventricular length, it receives 2 points assessment, and if the length of the branch is more than 2/3 from the length of the left ventricle, it receives 3-point assessment. The total points cover the whole myocardial area at risk, and this is, for example, how we measure in the circumflex with these small branches. As Dr. Ku already mentioned, and it is very important, the relative importance of the branches is dependent from with its length, not its diameters. So here you can see the relative importance of those branches. This is how we actually measure these branches and the relative estimate of the vessel. So this is a main vessel, this is LAD again, and diagonal branch. And you can appreciate that the relative importance, this is another estimate how we can judge about the importance of the side branch regarding the main branch, is the ratio of the two territories. I will show you on the next slides why this is so important. Or exactly at this bifurcation, the side branch territory mass is only 1/3 from the mass of the main vessel. And this is directly related with the FFR in the main branch and FFR in the side branch, which was significantly related. It is interesting that the side branch territory, myocardium at risk, was much more dependent and related with the FFR in the main vessel than in the side branch. And we defined that probably for the important side branches to give a significant FFR. This is a FFR at the beginning. That means that the FFR have a significant summary stenosis between main vessel and side branch ostium. You have to have a side branch myocardium territory more than 12% to have significant FFR at the beginning, and that means that this FFR should be treated. And what is the importance of this finding? Actually, this is directly related with mortality. There is a borderline trend to increase in mortality with small area side branches, and there is a definite influence of side branch territory. The smaller the side branch, the more is cardiac mortality. This is an expected finding, and this is we published in Nature Scientific Reports 1 month ago. And what was surprising actually, that the larger side branches are physiologically more important, but the smaller side branches have much more influence on the mortality at 5 years. And we developed a bifurcation functional significance score with inclusion of the side branch to main branch ratio as a prognostic factor with the relative weight of 1.5 in developing score for defining functionally significant bifurcation to predict the functionally significance of bifurcation. And this score gives almost 0.95 C statistics and very good, extremely good sensitivity and specificity to define which lesion is significant. That score was developed on a population of 172 patients, and afterwards it was verified for clinical outcomes at independent population of 555 patients. So as a rule of the thumb, what is important side branch? This is important side branch when its length is more than 2/3 than the length of the left ventricle. So in conclusion, the Barry score is easily applicable in daily practice. The large side branches with larger absolute and relative territory were more frequently associated with significant FFR, which means that they cause more functionally significant lesions. However, the cardiac mortality is significantly lower in patients with smaller absolute side branches territory. And we propose the bifurcation functional significance score as a new tool for assessment of functional significance of bifurcations. Thank you.
Okay, dear Dublin, thank you. Terrific data and I think important clinical issue. Maybe one more question. How would you comment the question, which role play in the decision making the fact sometimes we have normokinesia, sometimes hypokinesia, sometimes dyskinesia in the territory, which role play LV function or some regional problem with myocardial function?
At the moment, I could not say it because we excluded patients from our analysis. We excluded patients with the left ventricular ejection fraction less than 30-35. So generally, these are patients which do not have quite a significantly affected left ventricular functions. Only 1% from our patient had left ventricular branch block, and almost neither had some scars or something like that. So it is difficult to answer on your question, but definitely that means that our data could be applicable for patients with let's say normal or mildly reduced ejection fractions. And that means that we should be meticulous in achieving the maximum optimal result in the main vessel. This is what actually for mortality.
Yeah, would you see how important will be MRI in detection of viable myocardium in this setting? Would you recommend this or?
Definitely, definitely. Yeah. And we are planning to do a study. Probably it will be started in the second half of this year in our center.
Okay, so, I think this is very important clinical question. Okay, any remarks or comments, Robert?
Just one question. Yeah. Just one question. Once more, Dobrin, congratulations for such a big work. I had this opportunity, let's say, observing this data and some work on that. My question is regarding these small small side branches. Sometimes we have this kind of pattern with many septal branches, which during the LAD stenting are, let's say, a little bit looking bad. So what do you suggest in such a situation? Okay, we can improve with percutaneous treatments these applicable to our methods branches. What about this small one? How we should work, let's say, fight for them? And how it's important?
My personal tactic is just to put a wire and with a small balloon just to cross, even without inflation, just to restore the flow if there is some problem with. But in my opinion, and after our analysis, I'm not. How to say? I would like to say that I would not leave without treatment even the small branches. What means treatment? Means with the normal perfusion. Just
so
keep it open.
Flow.
Just keep it open.
So this is very, very important remark. We should take into consideration in every single case when we see any possibility to restore. We should do this. So thank you very much.
Yep, definitely. So now we go ahead with the next presentation, and the question is, so if we have to treat the side branch, and we started by provisional approach, so we have practically only two options. This is a tap or a culotte, and Professor Leszak will, I hope he is now online, he will make the presentation according to this point.
We have his presentation on record, and then we will discuss live.
Good.
Hello everyone, my name is Maciej Leszak, and firstly I want to thank the organizer for inviting me to this meeting, and I hope that that's really the last time we meet online. So my job is to talk on tap and culotte technique. Let's start with tap technique published many years ago in 2007 by Francesco Burzotta. And the technique, which is rather simple, the first steps are the same as in provisional strategy. There is no need for multiple rewiring. There is no double or triple layer of stand struts left as in crush or technique. And the side branch diameter is less important than in culotte technique. So when I use tap, in most of cases, I use tap when I planned a provisional strategy and I see that the flow to the side branch is compromised and I need to stand the side branch. Sometimes I also use tap as a planned two-stand strategy, especially if bifurcation angle is wide. So how much stand in the main vessel? This is an important question. In a culotte and mini crush, you see that the whole stand protrudes actually from the main vessel to the side, from the side branch to the main vessel, whereas in a tap technique, the protrusion is only partial. Actually, at the carina level, the stand protrudes into the main vessel, whereas on the opposite side, there is no protrusion at all. This is, of course, the ideal position, very nicely presented in one of the first presentation by Francesco, presented during EBC meeting in 2007. So let's have a look how it looks in a patient. So this is a result of provisional stenting of the LAD at the bifurcation with diagonal branch. And you clearly see that there is a small dissection left after kissing with some flow less than TME3. So I decided to stent the side branch with a tap technique. So here is a positioning of a drag-eluting stent, which is 2.5 over 24 millimeters long stent. And now the first crucial point is how to position the stent. This is the vessel, the main vessel, and you see that the protrusion of the stent ideally should be only a partial. Another important point is to park a main vessel balloon across the side branch that will be used immediately after stent implantation for kissing. So this is the side branch stent implantation. You see the ostium of the side branch, which is very often the case, is not adequately dilated. The stent implantation is followed by some release of the pressure in the main vessel side branch balloon and main vessel balloon inflation. What I often do after this step, I take an NC balloon and post-dilate the ostium of the side branch with a high pressure, and which is then followed by another kissing with two short NC balloons with a high pressure. So you see this is 30 and 275 short balloons, 14 atmospheres inflated each. Also, important thing is to deflate the balloons simultaneously in order to keep the neocarina, which will always be created by the two stents, to keep this neocarina at the position, at the central position, to reconstruct the natural fractal geometry of bifurcation. So now, if you want to finalize with final pot, which actually is recommended in this technique, you should be very careful with pot balloon positioning. And this balloon, the distal marker of the balloon, should be positioned away from the carina. Otherwise, as you see on the left-hand side of this image, you may push the carina back towards the side branch with some side branch ostium compromise, and this, of course, you will not see it on the angio, but in future, due to some turbulence and of the blood, some shear stress differences, there is there may be some higher risk of stent thrombosis or restenosis. So the balloon should be positioned like you see on the right-hand side of the slide, far away from the neocarina. And keep in mind that neocarina is completely not visible in angiography. So actually, you don't know how long this neocarina is. And the truth is that it is not very often that neocarina is that short, as nicely presented by Francesco many years ago. Actually, the length of neocarina is the consequence of two things. One, the angle of the bifurcation, and the other thing is the site of rewiring. So if you happen to rewire in a proximal strut, then the length of the neocarina will be slightly longer. The more distal you rewire, the shorter the neocarina becomes. And of course, the narrower the angle, the longer the neocarina. As you can see here in this example, if you manage to rewire distally and the angle is not very narrow, you will see this very favorable shape of the main vessel stent, and you actually you may deploy the side branch stent in more T than the TAP technique. I also recommend to look into the EBC white paper published in 2020 by Francesco Burzotta, when all the steps of TAP technique are nicely described in detail. So go please and see this paper, read this paper. So now we come to culotte technique, even older one, published by Bernard Chevalier in American Journal of Cardiology in 1998. And actually, this technique differ significantly as compared to what we do now, because Bernard started with main vessel stenting, which is the opposite to the current strategy, where we, in most of cases, start from more angulated vessel, which is a side branch in the vast majority of cases. So actually, when we perform culotte in a current fashion, we should call it not culotte but inverted culotte. So when I perform culotte, two things are important. Side branch has to be a sizable one, so the diameter of a side branch and the main vessel should be comparable. And the better the result, the narrower the angle, the better the result. So I try to avoid this technique if I see a right angle, like in left main, what in left main very often happens. Again, if you go to the EBC white paper on stenting technique, you will see all the steps in detail, and I want to just focus your attention to the pot, which actually should be performed in this technique 3 times. So the first pot after first stent deployment, just to avoid subliminal rewiring. Then, of course, after second stent implantation because of the same reason, and final pot. And here another warning, again the same warning, stay away from carina because you may deform the stent and compromise the flow to one of the branches. So if you manage to perform all the steps as recommended, you will see this very nice result. This is, of course, micro CT image on the bench. Recently, a study on double kissing culotte technique has been published by Gabor Toff. This is just a bench model study on 24 cases. And Gabor recommends decay culotte because of some possible stent deformation. You will see it in a minute. So actually you kiss twice. This additional kiss should be performed after first stent implantation. So you implant the mostly Cybran stent. You go through the distal strut, open up the struts towards the main vessel, and then you perform kiss followed by main vessel stent implantation, pot rewiring, etc., and final kiss and pot as in a regular culotte. So why this first kiss? So what Gabor observed on the bench was that if you don't perform the first kiss after second stent deployment, he observed a kind of deformation of the Cybran stent. You see it very nicely here, and you can imagine that now if you rewire through the proximal strut, you may happen to get your wire through this gap, and with kissing you will even enlarge this gap, which will lead to less stent, less drag within this area, and potential risk, higher risk of Cybran restenosis. Contrary to this, if you perform the first kissing before the second stent implantation, you will not observe this deformation, and that's why Gabor recommends to perform decay double kiss in this technique as well. Although it looks nice on the bench, we have no data, no clinical data, so it should be validated in some clinical study, and I'm sure that it will be validated soon. And to compare both techniques, we have one paper published a couple of years ago by Ferenc and Bad Krotzingen group, BBK2 study, when they randomized 300 patients 1-to-1 with bifurcation lesions requiring Cybran stenting to culotte or tap, 150 patients in both arms with 9 months angiographic follow-up and 12 months clinical follow-up. And the primary endpoint was diameter stenosis, and as you can see on the left-hand side, as the bifurcation as a whole, in a tap stenting group, there were more patients with more than 50% diameter stenosis after 9 months. But if you look at the right-hand side, you see that this occurred mainly in the side branch, whereas in the main vessel, there was absolutely no difference. In clinical terms, although target lesion revascularization was doubled in a tap stenting group, this difference did not reach statistical significance. So actually, we don't know whether it will translate into clinical outcomes. It may translate if the group number were higher, then perhaps it will translate also in clinical significant statistical clinical worse outcomes. I thank you very much for your attention. I wish you a great conference, and I really hope that next time we will meet in person. Thank you so much.
Yeah, I believe Maciek is not online with us, but his presentation was very clear, showed us which technical options do we have, and if we go by provisional, so definitely Culotte looks better. So it's we have less risk stenosis, and we have even better clinical follow-up. So we will go now with this data and present the 3 years follow-up very soon. The paper is practically ready to publish. Any questions or comments, Robert? Some remarks from your side, or Dobrin?
Yes, I have one question to you, because for me, you are a big fan of TAP. I was a fan of this technique since there's one year ago. I have some doubts in terms of standardization of the TAP technique. Some small differences in protocol can make let's say 2 different types of T techniques. So my question is, do you really do you think that we should still promote TAP technique, or how we should improve the results of TAP? Because theoretically this is very user-friendly technique. Yeah. But you know, it blame you for any mistake.
Yeah, I think very important remark we heard from Dobrin. Dobrin, you're absolutely right if you mention, okay, we go with provisional stenting approach, but still tend to, from my perspective, up to 20% of cases we need to treat side branch, and then we have option to go with Culotte, or we have the option to go with TAP. It's again the question of how is the bifurcation angle, etc. But if you go with a TAP, I think the majority of us earlier days, we didn't perform aggressive final kissing, and I think this was a problem with the TAP approach. If you go with a TAP, you need to take new non-compliant balloons and to go with pressure of around 18 atmospheres. Even in Maciek presentation, he mentioned 14. That's good, but nowadays I'm going even up to 18 atmospheres, and then again final pot. That's necessary, of course. And I think the main problem is that what we saw in our BBK study, we don't catch ostium completely with the side branch stent. This was the main problem of patients treated in the TAP group. So I believed initially, okay, it looks perfect, but finally in the re-angel, after 9 months, we saw if we zoom this area, this bifurcation area, we saw there was a gap, and this was in majority of cases. And then the point, yeah, it was wrist stenosis, whatever. It was a need to retreat this side branch ostium. We go now ahead with comparison of DK Culotte. This is already running in Bad Kreuznach in Germany. DK Culotte versus DK Crush in patients with a need for double stenting. So we will see the studies ongoing now. Okay, we go now ahead to the next presentation, and in some cases there is definitely a need for to perform double stenting and to start with a side branch stenting, and this is the option to use Crush or DK Crush approach, and I'm very happy to see Xiaolang Chen from Nanjing, according his presentation, an update of 2-stent technique in bifurcation treatment, Crush versus DK Crush.
Thanks, Dobrin and the BBC organizing committee for your invitation to present my approach to left main bifurcation lesions. So the subtitle is Central Position of Decay Quashi Study. This is Xiaoliang Chen from Nanjing, China. I have nothing to disclose. I will go through my presentation from number 1 to number 7. So basically, from angiography on the left panel, you can see usually it's very commonly to see the bifurcation lesion always involving both a main vessel and daughter vessels. But on the right panel, you can see the presence and the severity of plaque burden on the osteocyte branch depends on the geometry, particularly the bifurcation angle. So on the extreme right panel, you can see for the presence of inner curvature, just proximal to side branches will be large plaque burden and a very commonly unstepped plaque at the osteocyte branch. This is the basis of geometry to tell us the mechanism why bifurcation lesion, why always localized as a lateral wall of both vessels. So next, according to the Medina classification, particularly for distal left main lesions, so there are many different kinds of classification, varying from just distal to Medina 110, Medina 101, or Medina 111 or 0211. So the last two kinds of bifurcation lesion are classified as true coronary bifurcation lesion because the plaque burden localized as both sides of the main vessel and daughter vessel. But in terms of the false or non-true bifurcation lesion, including distal, Medina 110, Medina 101, but the plaque burden usually extended into the osteo-LAD or main vessel. So for such a kind of false bifurcation lesion, so provisional stenting technique is the mainstream, is a major choice for the treatment. But the things should be kept in mind are the extension of the plaque burden further protruded into the main vessel after stenting main vessel. Next, because of the very common presence of cranial shifting, so after stenting from right to left main, which is very easily to get the cranial shift to cause the severe pinched side branch osteum. So the change from provisional with one stent to provisional with two stent technique is unavoidable in some cases. But for the true coronary bifurcation lesion, two stent approach is rescued for most of the cases. But for some of operators, they are likely to select the two stent technique for this two true coronary bifurcation lesion. So number 3, let's go through one case. It's a 46 years young gentleman. Patient presented stem angina for 6 months and was admitted to hospital because of the acute coronary syndrome for only 1 week. Negative biomarkers, a very well reserved left ventricular ejection fraction. From the angiography from left to right panel, you can see as shown in AP caudal, so the distal vessel looks very good, but with very typical Medina 111 bifurcation lesion involving AD, single flash. So it could be classified by Medina 111 bifurcation lesion, particularly on the right panel. From spider view, you can see the lesion length in proximal single flash is at least 10 millimeters. Also, there is the taking off for the diagonal from very proximal LAD. So after angiography, we check IVUS from distal LAD to the main vessel. So on the left, you can see the left main looks very big. So the vessel diameter is more than 5.5 millimeters. Also, at the cranial point, we can see very long cranial between AD and the single flash on the left panel and also on the right top panel. So finally, you can see because of the very severe plaque burden at the osteo-LAD with mild plaque burden at the osteo single flash. So inevitably, two-stent technique should be the first choice But unfortunately, this patient was included in our DKQH5 trial, and the provenance stent technique is a candidate of stent for this patient. So because of the diffuse lesion from distal LAD to left main, so we prepared to stenting LAD distally. So finally, we used the 2 DS stent starting from very distal LAD. So immediately after 2 stent implantation in LAD, we have to use the third stent crossover from proximal LAD to left main. So on the left panel, this is the arrow cranial to show the exact position of the stent. So in general, stent was expanded very good, but the middle part of stent looks like an under expansion. Immediately after stent for left main, patient suddenly presented very severe chest pain. So you can show the ST from ST segment from V1 to V5 as well as in van and alveolar leads elevated very much. Also simultaneously, patient blood pressure dropped to 60/40 and heart rate slowed down to 40. So I had no sufficient time to take additional angiography to confirm the block of blood flow in the symphysis. So on the right panel, you can see I tried to rewire symphysis again using third wire after 2 attempts of post-dilation port technique. But finally, because of the gelled wire still in the symphysis, I used the 1.5 balloon along the gelled wire to restore the blood flow in the symphysis. So on the left panel, you can see immediate after the blood restoration in symphysis. So you can see there was a very, very critical stenosis compromise of the symphysis by the left main stenting. But angiographically, there was no any sign of thrombus formation. So after the blood restoration, I had sufficient time to revise symphysis, followed by repeat dilation and use a short stent. It was 3.5 by 18 stent to cover the osteosymphysis with another balloon pre-positioned in the LAD in left main. Finally, the whole procedure was finished by tap technique. So it means the stenting technique shifted from provisional to provisional with the 2 stent technique and the final kissing balloon inflation and the final port. So immediately after the procedure, so we found 10 times increase of CKB, also ST segment depressed from V1 to V4 leads. After stenting technique, except for the IOS confirmation, we also check OCT and the patient discharged from hospital after 2 days. So this is the final angiography from spider view to show very beautiful expansion of 2 stents in the LAD and the symphysis. So on the right panel, so it's OCT immediately after stenting symphysis, and also after final part. So from distal third to the left main, gradually you can see stent insert was fully expanded, no plug prolapse, no thrombus formation. But I tried to identify the change of cranial length. So finally, we measured the length of cranial was shortened to 1.1 millimeter, significantly shorter than the length measured by IOS. The final symphysis ostium minimal stent area was greater than 6 millimeters square. So it achieved the optimal procedure guided by IOS and OCT. So next, we have to address the importance of side branch lesion length. From our previously published DKQH2, DKQH5, as well as DKQH6 trial, there were a total of 702 lesions were treated using provenance stenting technique from intention. All patients were included in this 3 randomized trial. So at 1 year follow-up, we stratified the patient into 3 groups, so side branch lesion length less than 5 millimeters, between 5 and less than 10 millimeters, or minimal 10 millimeters, 3 groups. So from table, you can see the percentage of cardiac death, target vessel myocardial infarction, TLR, TLF, as well as stent thrombosis increased almost 1 to 2 times. So the preliminary data clearly indicated the very significant importance of side branch lesion length correlating with 1-year clinical outcome. So acknowledged Dr. Julia and his team to perform meta-analysis. Finally, they found side branch lesion length minimal 10 millimeters also is a key independent of 1-year clinical outcome of the different studying technique. So this was the reason why we needed to create our definition criteria to separate simple from complex bifurcation lesion. Basically, the criteria came from 1,550 patients with coronary bifurcation lesion between 2004 and 2006. This cohort of patients served as a study group. Immediately after the establishment of this criteria, we needed to test its efficacy in another external validation group, including 3,660 patients with coronary bifurcation lesion. This is the final box showing the items of definition criteria. So in general, for left main and non-left main bifurcation lesion, the general requirement is the side branch lesion length minimal 10 millimeters, plus side branch baseline diameter stenosis minimal 70% for left main bifurcation and 90% for non-left main bifurcation lesion. These are only 2 items in major criteria. Also, we provide 6 minor criteria as shown in the right panel, including greater than mild calcification, multiple lesion, bifurcation angle less than 45 degrees or greater than 70 degrees, main vessel reference vessel diameter smaller than 2.5 millimeters, main vessel lesion length greater than 25 millimeters, as well as thrombus contained lesion. So for any given bifurcation lesion, 1 major criteria plus any 2 minor criteria are used to define complex bifurcation lesion. Since the development of this definition criteria, we, for the first time testified the difference between provisional and DK-Quashi technique from our DK-Quashi 5 trial, which compared DK-Quashi and provisional for distal left main true coronary bifurcation lesion. From figure, you can see on the right panel, in terms of the complex bifurcation lesion defined by definition criteria, after 1 year, the TF rate was 18.2% of the provisional, significantly higher than 7% of the DK-Quashi technique. But on the left panel, for simple bifurcation lesion, even the absolute digital number of 1-year TF after provisional was high, but there was no significant difference between 2 groups. This could be explained by small sample size on the left panel among patients with simple bifurcation lesion. So finally, we designed, conducted, and published our definition 2 trial. It was a multi-center randomized comparison of 2-stent and provisional stenting technique in patients with complex coronary bifurcation lesion. It's a definition 2 trial. So study flow chart showed finally 325 patients in the provisional and another 328 patients in the 2-stent group. The study was conducted from 49 international centers. So the primary endpoint was the 1-year TLF. Safety endpoint was stent thrombosis at 12 months follow-up. Secondary endpoints including mortality, cardiovascular death, incident stenosis, myocardial infarction, TLR, and TVR. At 1 year follow-up, the rate of 1-year TLR and tidal vessel myocardial infarction was 5.5% and 7.1% after provisional, compared to only 2.4% and 3% after 2-stent technique, leading to significantly higher 1-year TF rate after provisional stenting technique compared to only 6.1% after two-stent technique. From this trial, among patients underwent two-stent technique, more than 80% of the lesions were treated using DK-Quashi technique. So we could conclude, we could propose that DK-Quashi is superior to provisional stenting technique for real complex bifurcation lesion defined by definition criteria. So next, the figure showed the general comparison of left man versus non-left man bifurcation lesion of the different stenting technique. From left, you can see for left man bifurcation lesion at 1 year follow-up, there was a high rate of tight lesion revascularization compared to non-left man bifurcation lesion. But on the other hand, standing left man bifurcation lesion had relatively significantly low rate of tight vessel myocardial infarction compared to non-left man bifurcation lesion. So the partial explanation for this finding could be the presence of some, even not many, tiny side branches around a bifurcated area in patients with non-left man bifurcation lesion. So also the finding also indicated the importance to make our stenting procedure for left man bifurcation lesion as perfect as possible to minimize, to reduce the occurrence of TLR at the 1 year follow-up. Furthermore, for both left man and non-left man bifurcation lesion, we tried to compare provisional stenting technique and the DK-Quashi technique in terms of the 1 year TF rate. So from the figure showed at the bottom, you can see for left man bifurcation lesion, DK-Quashi is associated with low rate of TLR as well as tight vessel myocardial infarction, leading to a significantly reduced rate of target lesion failure. But for non-left man bifurcation lesion, the superiority, the strength of DK-Quashi was the reduction of target vessel myocardial infarction, and no effect on the percentage of target lesion revascularization. So from these three figures, we could conclude that stenting distal left man bifurcation lesion should be very cautious because the complex anatomy will indicate the high presence of the tight lesion revascularization, particularly after provisional stenting technique. But for non-left man bifurcation lesion, we have to be very, very seriously to protect as much as possible of side branch. So the slide, I'd like to show the latest version of DK-Quashi technique. This animation was created by my colleagues from China. So I think it will take a very short time. So in conclusion, my approach to left man bifurcation lesion is for any given left man distal bifurcation lesion, the first step to classify the bifurcation lesion according to Medina classification. For false bifurcation lesion, the first choice must be provisional stenting technique. On the other hand, for true coronary bifurcation lesion, definition criteria is very, very effective to classify the risk of bifurcation lesion. For simple bifurcation lesion, we still prefer to recommend prominent stenting technique to be as a first treatment. But for complex bifurcation lesion, two-stent technique, particularly decay crush technique, should be selected. And also through the whole procedure, intravascular guidance, including IVUS OCT as well as FR, is very important to improve the clinical outcomes. Thanks for your attention. Thank you.
So thank you, Xiaoliang. Yes, Mirek?
Yeah, thank you to Dr. Chen, but probably he is not online now. I'm not sure.
No, he's not, and he's not able to be with us alive. He has some personal arrangements, so he cannot connect now.
So at least according to the complex distal left main bifurcation, the data we have at the moment is very clear. So then there is no doubt decay crush should be and must be preferred approach if there is really long subtotal stenosis of the side branch. I think this is, from my perspective, clear. But still, we have in majority of cases normal non-Chinese bifurcation lesions in the distal left main. And according to our European data from ABC main study, so we can be also very convenient to treat such patients using a provisional approach. So in around 80% of patients, we can achieve a very good clinical follow-up after 1 year. Yeah, maybe some comments from Maciek. Welcome, Maciek, and from Robert.
Oh, hello, guys. Yeah, actually, I like very much decay crush in very complex situations, and I use it often especially when the main vessel is at some risk, because this technique gives me, the protection of the main vessel throughout the whole procedure. So sometimes, especially if the main lesion is located distally to the bifurcation, and there is really a complex lesion, I prefer decay crush to culotte, for example, which is also widely used and in most of cases a very safe and very efficient procedure. And I think the definition criteria Xiaoliang Chan mentioned are really, very good criteria to tell if the bifurcation is complex and really will require complex technique. And in these situations, probably complex techniques will give some advantage in clinical terms to the patients.
Sorry, just we noticed with Yves on this animation now, which Dr. Chen demonstrated, that they actually added 2 steps additional to decay crush. This is
the first one is to crush first with a balloon adapted to the distal bed, then to recrush with a balloon adapted to the proximal bed, and the second point is before this one is to do a high pressure with a bigger balloon inflation in the side branch, just to open. This will remove the risk of crossing outside the stent close to the carena. And if it's effective, it seems to be effective, then you can go back to the rule we have, which is to go back to the side branch through the most distal cell. With the traditional decay crush, was improved after years and years, beautifully done by Xiaoliang Chen. With this new additional step, you can remove the risk of crossing outside the stent. So at that time, you can enter the distal cell.
Yes, there is a modification, definitely, and this technique, which he demonstrated now, is different from the technique from maybe 3 years ago.
Was built with experience, exactly. And the same was done for provisional. Just a comment on the case he showed of circumflex occlusion. I was discussing this morning that when you are sizing your stent, when you have a lesion on the ostial LAD with remodeling, you are sizing your stent on media to media, Then you have you will get the same diameter in proximal LED and left main, and close the circ. You will close the circ for sure. I have cases. Claude Maurice did a case like this during TCT. She reopened, of course, but the rule for me is to, at the price of undersizing a bit the deployment of the stent in the main distal vessel, for example, 3.5 inflated at 6, yet you are, and immediately go to the pot, then you are preserving the bifurcation of moving the carena. And after that, you can, of course, go back to the LED at the end of the procedure to finish. That's not a problem. So I think it was typical of a too big stent. Typical. Also, you can solve also the problem. He told he saved the situation by doing a pot, which is very clear. All along the procedure, you have to preserve the double diameter, the proximal and the distal. If you give the distal main the same diameter as proximal main, you are closing the side branch. So it just, subtlety. Yes, a lot of subtleties in decay crush, but in provisional too. Even to perform most complex procedures.
And perhaps one more comment: if you stick to the advice just Yves mentioned, this complex procedure becomes, in most of cases, very easy, because you will recross very easy. You will deliver the balloons. The kissing is easier. So if you keep it in mind, if you stretch the struts of the cells of the stent with big balloon, if you crush it adequately, then the procedure is really easier than we used to do it many years ago.
Yeah.
Just short comment, if you don't mind. First of all, this is the merit of intravascular visualization techniques, that we know much more about the necessary additional steps which should be done to improve the results. This is very important. And this is also the merit of European Bifurcation Club, that these bench tests, which are spreadly, are performed in many centers, realized us how not perfect we were. So it means that we should keep our eyes on the new ideas. We should test all of these things which we estimated as the golden standard. So we don't have gold standard. We should improve. We should make on development.
Sure. So
I would suggest probably there are no any more questions even in the chat function. So I would close this session. Thank you to Robert, and thank you to Marcin and to Dr. Koo, who is not anymore online. And I would suggest we skip now to the next session. Thank you so much, and see you soon.
Thank you. See you soon.